Well, good evening, everyone, and thank you for joining us. This is our first rare and challenging oncologic case competition, and this is sponsored by the Florida chapter of the American College of Surgeons Commission on Cancer Committee. We solicited cases from medical students, residents, and fellows from programs across the state. We got 24 different abstracts of cases, and then the Commission on Cancer Committee judged those cases. And tonight we have presentations from the top three. So we are looking forward to looking forward to that. First, I'd be remiss if I didn't thank the Commission on Cancer Committee for reviewing all of these cases, as well as to Doctors Wynn, Awad, and Moeller for being on tonight to judge the cases. And I would certainly be remiss if I did not thank Amber with the Florida chapter of the American College of Surgeons for all the work that she did getting this all set up and situated for tonight. So thank you very much to Amber. Basically tonight we have three cases. We're going to have each of them present for approximately 15 minutes or so. And then there'll be 5 minutes to switch over cases as well as to answer any questions. So if you have any questions, just put them into the chat box. And then I will ask those questions in the between time. And so our first case tonight is a case of low-grade fibromyxoid sarcoma in a pediatric patient by Minji Kim. She is a medical student at the University of Miami School of Medicine in Miami. Ms. Kim, take it away.
Thank you so much. It's quite a privilege to be here. So my name is Minji Kim. I'm a third-year medical student at the University of Miami, and I'm here to present a pediatric case of low-grade fibromyxoid sarcoma. So upon initial presentation, we had a 12-year-old Black female presenting with an 8-month history of a slowly growing mass on the volar aspect of her right index finger in the proximal phalanx. Patient initially reported mild functional impairment and tenderness, and her primary complaint was that she had difficulty with handwriting at school secondary to pain. And that's where the mass was. And upon physical exam, she had a 3 and 2.4 centimeter mobile, non-pulsatile transilluminating mass. She had limited full index finger flexion at the proximal interphalangeal joint, but had full active range of motion of the other fingers. A positive Tinel sign was appreciated upon percussion of the mass. The first plain radiograph of the right index finger showed soft tissue swelling on the volar and ulnar aspects of the proximal phalanx, as shown in the green boxes. There was no invasion to the bone structure, and upon this exam, it appeared very benign. So the patient underwent a marginal excision. Intraoperatively, the mass was well encapsulated, multiloculated, fluid-filled, and palatable. And based on the gross inspection, as shown in the photo below, the mass was thought to be a giant cell tumor of the tendon sheath. And the marginal excision showed negative margins. The tumor was sent for pathology, and the immunohistochemical study showed reactivity for MUC4 and was focally positive for EMA and BCL2. It was negative for SMA, Desmin, MyoD1, myogenin, BRAF, S100, and CD34. The CT scan of the chest without contrast was normal. And with this, the diagnosis of low-grade fibromyxoid sarcoma, or LGFMS, was made. So what is LGFMS? It is a very rare soft tissue tumor that occurs in the proximal extremities and trunk among young adults, the median age being about 33 years old. It represents fewer than 5% of soft tissue sarcomas, and it is a distinct entity from other soft tissue neoplasms. Little is known about the occurrence of LGFMS in the distal upper extremity because it's more common in the proximal extremities and the trunk. Therefore, the diagnosis of LGFMS is often missed and misdiagnosed as lipoma, ganglion, or infection. Also, One study looked at the outcomes of LGFMS, not limited to just the distal upper extremities, but overall. And this study showed that about 63.6% of the patients had local recurrence after a median of 3.5 years, and about a half of patients had metastasis, with the majority of the metastasis being to the lungs and the pleura after about 5 years. And this study also showed that metastasis can occur even after 45 years. Currently in the literature, the recommended treatment is white excision with normal margins, and it has been shown to help avoid local recurrence. Negative margins are the most critical component in treating LGFMS. And because LGFMS has a very low mitotic rate, it may not be very chemo or radiosensitive, and adjuvant therapy is not necessary. The dilemma that surgeons undergo is negative margin versus function. So negative margin is very important to achieve success. However, given that this tumor is in the distal upper extremity, it may be difficult to achieve negative margins without an amputation because of the complex anatomy of the fingers, as well as the lack of redundant tissues. So amputation may sometimes be the only approach. However, this will compromise the function, especially in our patient, given that she was a 12-year-old patient. You don't want to compromise the function too much, especially because this was in her dominant hand. And the fact that this tumor was growing in a very space-sensitive region makes it difficult to assess the margins. And because our surgeons was able to achieve negative margin, they decided to proceed with careful observations and follow-up instead of fully amputating the finger to maintain some form of function. During the 2-month follow-up, the MRI had no evidence of local recurrence. However, during the 4-month follow-up, the MRI started to show heterogeneous nodule with areas of mixed hypoechoic and echogenic tissue. During the 6th-month follow-up, the patient presented with pain radiating down the ulnar aspect. There was a 3 × 2 centimeter mass that progressed into the blood vessels and to the nerve of the middle finger. And as a result, the tumor board, patient, and the family decided to proceed with the right index finger and middle finger ray amputation and intrinsic muscle reconstruction and targeted muscle reinnervation. And in hindsight, we wondered if an initial amputation of just the right index finger would have helped us salvage the middle finger. But given that the surgeons were able to achieve negative margins and the low mitotic rates of LGFMS, we still believe that we made the right decision of initially just observing the tumor after the marginal excision. This was the patient's ability to write after 2 weeks of the amputation.
Take your time.
As you can see, despite having her right index and middle finger amputated, she was still able to fully write after 2 weeks.
Take your time.
And this was post-op for 5 months. This was actually last week. And the patient was able to fully adduct her thumb and fully form a fist. And she even told the surgeon that she was trying out for her volleyball team, which was very exciting to hear. So why is this case very unique? First, it occurred in a pediatric patient. So LGFMS commonly occurs in young adults, the median age, like I said, being 33 years old. One study by Evans reported that of the 33 LGFMS cases, only 3 occurred in a pediatric patient. And those 3 were not in the distal upper extremities, but were instead in the inguinal area, neck, and deltoid. Another study by Chamberlain reported 102 patients with LGFMS, and there was no patient below the age of 18. So the fact that this tumor occurred in a 12-year-old patient was rare itself. Next, it occurred in a hand distal upper extremity. So only 1/5 of all soft tissue neoplasms occur in the upper extremity. More common ones include the epithelial sarcoma, synovial sarcoma, clear cell sarcoma, and malignant fibrohistiocytoma. And unfortunately, this is why the diagnosis of LGFMS is often missed and misdiagnosed. Lastly, the rapid local recurrence of the patient's tumor. Our patient had a local recurrence after only 4 months of the marginal excision. Other studies show that LGFMS have local recurrence in about 2/3 of the patients after a median of 3.5 years. This specific study had one patient who had a local recurrence after only 5 months, but this patient had a positive marginal excision rather than a negative marginal excision, which is the preferable approach. Another study showed that 21.4 of the patients had local recurrence after a median of 2 years and 9 months, and the shortest in this study was 6 months. So overall, it was quite unexpected to see a local recurrence after only 4 months post-op. So recommendations from now on is that surgeons must consider LGFMS as a differential when encountering a mass in the hand or distal upper extremities, even in pediatric patients, even though the median age for LGFMS is in the 30s. Lastly, indefinite clinical follow-ups are recommended because, as shown by our study, the local recurrence occurred only after 4 months. However, in other studies, there were metastases that occurred even after 45 years. So you really don't know when the local recurrence or the metastasis can occur. These are my references and any questions. And thank you very much.
That certainly is quite an unusual and very interesting case. And so I'll just remind everyone, your chance to ask questions is by asking questions into the chat box. Otherwise, you'll just be stuck listening to me come up with questions. There is a question, and that question is, what is the recurrence rate of amputation versus local excision? Are you aware of any data that compares those two modalities?
What is the recurrence rate? I actually don't know the difference. I did not find any studies comparing amputation versus local recurrence. There were studies that looked at amputation versus, what's it called? Reconstruction. Like it was like a reconstruction, and the data was very similar, showing that amputation may not always be the best approach to LGFMS. However, there's very limited studies looking at the LGFMS of distal upper extremities, which has a very different treatment regimen to LGFMS in different anatomical regions.
One of the questions that I had, and I don't know if you can speak to it, I will just confess my ignorance. The targeted muscle reinnervation, can you speak to that as to just a little bit about what that is and what the benefits are for this patient?
While I'm not too sure about like the surgical management of the targeted muscle reinnervation, I believe it is to make sure that the functions of the index and the middle fingers are preserved in a way, because even though the muscle's not there, it can be reinnervated to the other regions so that the function, like as you could see in the video, she was still able to write.
All right, we're getting all kind of questions now. Let's see.
Okay.
You mentioned in retrospect, conservative resection was detrimental. How would you change your approach if you saw a patient similar to this? I think she's referring to the comment you made about if you'd amputated one finger, you might have been able to spare the second finger.
I don't know if the approach would be different if I were to see another patient, only because I think this case was unique in the sense that the local recurrence occurred so quickly. And often it has a low mitotic rate, unless that's different for distal upper extremity LGFMS. But with the literature search I've done, it actually has a lower recurrence rate than other regions. So I don't think I would change the approach.
That dovetails to the question that follows, which is, Do you think there was, do you think the margins were really clear since this recurred so quickly?
Yeah, so this is a conversation I had with the surgeon actually last week. So the wide excision that is recommended is 2 centimeters. Sorry about that. It's 2 centimeters. The surgeon noted that she was able to achieve a negative margin of 1.8 centimeters. So unless that 0.2 centimeters was, I mean, it always could be why the tumor recurred within such a quick period. But the pathology reports was showing clear margins. But there was that missing 0.2 to be really precise.
If someone develops pulmonary metastases, what is the treatment?
That's a great question. I'm sorry, I do not know the answer to that.
Speculate, although I don't know. I wonder if it's like many sarcomas that you know, there are some chemotherapy options, and I think it would depend on the number of mets as to whether one could do a metacystectomy or not. I guess one question that I had, kind of thinking through this. Okay, there's another couple of questions. We'll do those because they're better than mine. Sarcomas like this may infiltrate under the tissue, and compartment resection can be recommended. This is difficult to do in a finger. Should radiation have been considered due to the margin being less than ideal?
So with the literature search I've done, reports that had radiation done actually had more complications from the radiation rather than benefits. So for LGMFMS in general, radiation is not recommended. And then what is the overall survival rate given a high rate of distant metastasis? I believe the survival rate is still pretty high. I can pull up the exact number. Sorry, can I stop sharing? Is that okay?
You can certainly stop sharing.
I think I have the number. The overall survival rate is 55% after 5 years. So distant metastasis, while it can occur, and one study showed even up to half of the patients, it seems that the survival rate is still quite high, 55%.
This is a very, this is certainly a very interesting tumor, being that it's low grade, but sure seems to locally recur and seem to like to metastasize. We'll ask one more question, which is, you know, would there be any role for considering chemotherapy? You know, she specifically asked about neoadjuvant chemotherapy. You know, could you give chemotherapy? Would it have a response? You know, could it shrink down, help with resection? Things I think is where that is where this question is going.
I think similar to the radiation earlier, it's not recommended and it was not considered in this case.
Minji, I appreciate it. I know that this is this can be a challenging thing to present to all these surgeons, and so we appreciate it. We wish you well in applying for surgery residency, and thank you so much.
Thank you very much for this opportunity, and thank you for all the questions. I really appreciate it. I'll share them with the attending too.
Very good. We will start switching over. Our next presentation is entitled "A Giant Necrotic Adrenocortical Sarcomatoid Carcinoma." And this presentation is by Dr. Joel Prince. He is a resident at Brandon Regional Hospital in Brandon, Florida. So if you want to take it away, you are welcome.
All right. Well, thank you, Dr. Wilson, for the introduction. Today I'll be presenting titled in presentation, "A Giant Necrotic Adrenocortical Sarcomatoid Carcinoma," in lieu of Dr. Laura Pia, who is currently traveling to her home country of Ghana for vacation. So this is a patient of ours. She was a 60-year-old female with no significant past medical or surgical history, who presented initially with complaints of abdominal pain that had worsened over the past 4 months. It was associated with early satiety and nausea, and she noticed significant weight loss during this time. Of note, her past medical history was limited, possibly due to her limited use of doctors. She was uninsured, and that may have been part of it. Additionally, she had a 20-pack year smoking history, and of other note is her family history. She had 2 brothers, one of which had bone cancer, and the other with leukemia and brain cancer. So initial CT demonstrated a large left upper quadrant abdominal mass measuring 14 by 11 by 15 centimeters. And for this, the surgical oncology service was consulted. On our initial evaluation of the patient, she was very malnourished and underweight. She only weighed 45 kilos and had a BMI of 15. She had an obvious palpable mass in the left upper quadrant that was non-tender and made her abdomen somewhat protuberant. She had an elevated white count and low albumin as well. So I'm just going to have one of our radiologists go through some of the imaging here.
Hello, this is Dr. Bilal Saleh, an interventional radiologist. The images provided demonstrate a 16 centimeter by 11 centimeter by 17 centimeter large necrotic mass associated with peripheral mural nodules and thick septations. The mass is predominantly left retroperitoneal in location, likely originating from the left adrenal gland and exerting significant mass effect on the surrounding organs, including the stomach, the kidney, and the spleen. The images demonstrate inferior displacement of the spleen into the left lower quadrant, posterior displacement of the left kidney, and displacement of the stomach superiorly and anteriorly. Given the location of the mass in the left retroperitoneal space, the differential consideration for a large necrotic mass in this location would be adrenocortical carcinoma and retroperitoneal sarcoma. Given the appearance and the location in this specific patient, the findings are highly suspicious for adrenocortical carcinoma. Thank you.
So with those images, I hope you could appreciate how it was pushing on a bunch of nearby structures along with most of the vasculature to the organs that it abutted. So again, the differential diagnosis based off her presentation and the imaging was first adrenocortical carcinoma, second a retroperitoneal sarcoma, and then a little bit lower down on the list was a GIST or a renal cell carcinoma. So further workup of this, obviously she had a white count when she came in, and it continued to be elevated throughout her preoperative course, but ultimately did not demonstrate any infectious etiology. All cultures were negative, and it was thought that this was maybe related to the large necrotic component of the tumor. Since this was concerning for adrenal mass, she underwent biochemical testing, and it appeared that it was non-functional. And then further staging, we obtained a chest CT, which demonstrated no evidence of pulmonary metastases, just only COPD changes. And then finally, due to the close involvement of the left kidney and possible need for resection intraoperatively, we performed a renal nuclear scan, which demonstrated that most of her renal function was coming from the right kidney, and only 9.4% was from the left. So after discussing the various options with the patient, we came to a joint decision that due to her symptomatology that we would proceed with surgery first. We took her to the OR and proceeded with exploratory laparotomy through a midline incision. We surveyed the abdomen, looked for any evidence of metastases with the aid of intraoperative ultrasound, and then proceeded. This was the picture upon opening, and I think it's interesting to note how far the transverse colon is in the pelvis, and you can see the spleen already in the left lower quadrant. We proceeded by mobilizing the splenic flexure and opening the lesser sac. And it was clear once we did that, that not only was the spleen, but the stomach, pancreas, they were all draped over this mass. And so initially, to try and begin mobilization, it was evident that we were going to need to perform a splenectomy. We ligated the splenic vessels distally near the hilum, and then performed our splenectomy. Next, we worked on mobilizing the pancreas and freeing that from the mass. We began inferiorly, working superiorly. In doing so, we were able to dissect the body, the neck, the body, and the tail of the pancreas completely off the mass, along with preserving and identifying the SMA, SMV. We subsequently noted that the kidney was densely adherent to the mass, and as we suspected preoperatively, we would need to resect that in block. We identified the ureter and the glomerular vessels, which were ligated and transected. And then we began by mobilizing the mass inferiorly, laterally, and posteriorly as much as we could. It was stuck to much of the vasculature medially, and so then we proceeded to dissect more superiorly next. It was noted that the mass was adherent to the diaphragm, and this was unfortunately probably the thinnest part of the tumor. And while we were transecting a portion of the diaphragm with the stapler, the tumor fractured. There was some spillage of necrotic material, but that was controlled, and the fracture line was repaired. Subsequently, noted that the mass was adherent to the posterior superior aspect of the stomach. And so to resect it from the stomach, we ended up performing a partial gastrectomy, somewhat in the style of like a Colley's gastroplasty. We initially passed a bougie through the esophagus and had to transect or fire our initial staple load parallel to that bougie. And then once we were able to transect the mass away from that plane, we were able to subsequently transect the posterior fundus with several loads of the stapler, keeping in mind of where the left gastric was that was identified and preserved prior to performing the partial gastrectomy. A leak test was performed, which was negative. Subsequently, we turned our attention to dissecting the mass immediately off of all the vessels. We did this by initially following the splenic vessels proximally, dissecting those, and subsequently skeletonizing the celiac vessels off of the mass. The mass was adherent all the way to the origin of the celiac vessel. And once we had freed it from there, we subsequently dissected it off the aorta in the cephalad direction. Finally, we transected the renal vessels and removed the specimen en bloc and sent it to pathology. Before closing the abdomen, we left a drain by the tail of the pancreas, and we also placed a feeding jejunostomy. The patient overall did well during the surgery. She was not on any vasopressor support. The operative time was 5 hours and 41 minutes approximately, and there was about 350 estimated blood loss. Here are a couple more pictures from intraoperatively. You can see that first picture that we're beginning to mobilize the pancreas, which is draped over this mass from the inferior aspect. The picture on the right, the patient's head is to the right of the screen, and the pancreas is underneath the thumb of the operator, and we're beginning to follow those splenic vessels more proximally to try and mobilize the mass off of the vasculature. Again, this is a similar picture. And then subsequently, this is a picture where we're trying to staple the mass off of the diaphragm. So after all that, the patient had a pretty uneventful postoperative course. Due to the negative leak test, we started her on clear liquid diet postoperative day 1. We were able to advance her diet as tolerated. And she was subsequently discharged home postoperative day 6 with just nocturnal tube feeds and just a soft diet as tolerated throughout the day. We saw her in follow-up and administered post-splenectomy vaccines, and she was subsequently referred to medical oncology, who initially performed a PET scan, which didn't demonstrate any evidence of metastases or recurrence. And she has subsequently been referred to a tertiary medical oncologist. So these are some pictures of the specimen. You can see it's multilobulated. The picture on the right demonstrates how it's densely adherent to the kidney, which you can kind of see poking out in the background. This is after it was sectioned. You can see that it, again, is adherent to the kidney, but it doesn't seem to be invading the kidney, but rather pushing on the parenchyma. And also of note is that the specimen was mostly necrotic, and you can see that here within the inside. So unfortunately, I wasn't able to get any pathology slides on this because all of our specimen was sent to Moffitt for further evaluation. But I do have the pathology report. So final pathology demonstrated that this was an adrenal cortical carcinoma. It was poorly differentiated, and of note was that it was predominantly sarcomatoid components. And like I said before, there was extensive necrosis, and this made up about 90% of the mass. Due to our limited resections, there was a benign gastric mucosa on the mass, along with benign renal parenchyma, and all the margins were free of tumor, which put this at a T4N0. We sent the spleen, which was benign, and there was several hilar lymph nodes that were also benign, and one celiac lymph node that we sent was also benign. So I wanted to discuss adrenal cortical carcinoma a little bit. The incidence of this tumor is about 1 to 2 cases per million population per year. It's a very rare tumor. About 5 to 10% are associated with some hereditary syndrome, one of the most common being Lee-Fermeni. And that may have had some degree of influence on the tumor characteristics of this patient. She did have a significant family history for 2 brothers, again, one with brain cancer and one with bone cancer. Most of the hereditary ACCs are seen in children, but it still is a possibility in adults. There are 3 different histologic variants that compose 10% of all ACCs, 90% is wild type. Those include oncocytic, myxoid, and sarcomatoid, with sarcomatoid being the most rare. And so this case that I'm presenting will be the 16th case that we were able to find reported in the literature of sarcomatoid adrenal cortical carcinoma. Of the limited studies that have been done, one was looking at different mutations that seem to lead to the sarcomatoid variant, and they found that the Wnt beta-catenin pathway and possibly the p53 pathway both can lead to that dedifferentiation. Reviewing the reported cases, sarcomatoid ACC is a little unique from wild type in that upon presentation, nearly 75% of the patients present with metastases, whereas ACC is less, closer to 50%. Our patient was unique in that she didn't have any evidence metastases on presentation, and then with the postoperative PET scan, there wasn't any evidence either. It's a sarcomatoid. While it's the most rare variant, it's also the most aggressive and has the worst prognosis. So it's been noted that there's an 80% recurrence rate within 4 months amongst this variant, and nearly a 100% mortality rate within a year, with the median survival being 7 months. Several factors have been shown to be linked to a poor prognosis, and that's limited surgical resection and the evidence of distant metastases, which makes sense. And given its rarity, it's kind of hard to find any guidance in terms of the ideal oncologic treatment for this cancer. But it's one thing that is clear is that the best outcomes are achieved when complete surgical resection can be performed. That includes limited metastectomy if needed. Several different adjuvant therapies have been tried. These include chemotherapy, mostly cisplatin based. Midotane has been used as well, and radiation, but that seemed to be more used in palliative sense for like bony metastases. So in conclusion, this was a 60-year-old female who presented with a rare large sarcomatoid adrenocortical carcinoma. Despite the size of the mass, initially there was no radiographic evidence of distant metastases, which is rare. It would fall in the 25% that don't demonstrate that characteristic. Fortunately, we were able to provide complete radical excision of the mass, which, as I described, is probably the one of the most important factors in treating this sort of tumor. And it was also one of the most challenging aspects of this case, given the size and the abutment of the nervine structures and vasculature. And currently, she's pending evaluation for further adjuvant therapy. So takeaways from this case, the most effective treatment is complete surgical excision, including metastectomy. Adjuvant therapy is not well defined, but I think in this patient's case, putting her at stage 3, I think it would be of some benefit. And obviously, due to the high recurrence rate of this histologic variant and the overall poor prognosis, close follow-up is imperative. So these are my references, and I'd be happy to answer any questions. I'd like to thank you all for your time.
Thank you, Dr. Prince. We have time for a couple of questions, and there are a couple of in here. One is a couple of people have commented on vaccines, so we'll come to that here in a second. But Dr. Redan asked if there was any consideration for any kind of preoperative 3D imaging for pre-procedure rehearsal. He's found it useful in these types of cases that might have helped you decide to give vaccines preoperatively, because you might have known that the spleen would need to go, might have helped you prepare for diaphragm reconstruction. And I believe he shared this with everyone. There were 3 different links that he suggested in terms of programs like that. But was there any consideration to using any of those programs?
No, that's not something I'm actually familiar with or ever done, but it does sound like it would hold quite a bit of benefit, especially in this case where there's so much involvement of adjacent structures. We were pretty sure that we may need to take the spleen, given how, if you remember back in the initial CT images, the splenic vessels were pretty much just running over the top of the mass and involved in like a desmoplastic reaction. And I guess I'm not sure, again, I haven't used it, but our diaphragmatic resection was pretty limited. We were able to just, like I said, fire a staple load or 2 across the diaphragm. And then we just oversewed that with a non-absorbable suture.
Can you clarify the reason for partial gastrectomy rather than just mobilization? Was there tumor infiltrating the stomach? And as a second part to that question, she asks, why no preoperative vaccines?
So let me answer the preoperative vaccine question first, since I failed to answer it the first time. I had kind of mentioned that the patient was uninsured and it was a difficult social situation. And that played a part into, kind of put surgery first, and additionally didn't give us much time in terms of trying to arrange outpatient vaccines, because some of those vaccines aren't available inpatient to our patients here at Brandon. So her uninsured status played a little bit of a part into that. As far as needing to perform a partial gastrectomy, when we got to that portion of the case, there really wasn't a plane between the stomach and the mass. Just like there wasn't really a plane between the kidney and the spleen, although the spleen a little bit more so. And so due to its involvement, due to the fact that this could have been a GIST, we did a limited resection there.
There are a couple other questions, but in the interest of time, I'm gonna move us to the last case so we can stay on schedule. So if you want to unshare, we'll have our last presenter get set up.
Thank you.
Thank you for presenting, and always amazed at the cases that come out of Brandon Regional. Our last presentation is on natural killer T-cell lymphoma of the vocal fold, a rare laryngeal malignancy during COVID-19 pandemic. This is by Sham Roslin. He is a medical student at Florida International University, Herbert Wertheim College of Medicine in Miami.
So good evening. My name is Sham Roslin. It's an honor to be speaking with you today. I'm presenting about a case of extranodal natural killer T-cell lymphoma of the vocal cord, a non-Hodgkin's lymphoma. This is an extremely rare lymphoma with just one reported case of it centered on a vocal cord. The symptoms at presentation and treatment adjustments made due to COVID-19 infection and anemia make this case unique. So we'll begin with the patient's presentation to clinic. So a 57-year-old non-smoking female presented with a 2 to 3 month history of hoarseness. Medical history was notable for allergic rhinitis and a right vocal fold granuloma successfully treated with oral steroids 7 years prior. Her vocal quality fluctuated daily and worsened with strong odors. She denied dysphagia or reflux symptoms. The patient was a florist and identified herself as a Jehovah's Witness. So notably, the review of systems and the physical exam were negative for further findings, such as type B symptoms. Note her temperature here is not elevated and the lack of cervical lymphadenopathy as well. So the patient underwent video strobolaryngoscopy to evaluate the structure and function of her larynx. The procedure revealed a large keratotic mass that completely encased the left vocal fold. It extended inferiorly past the laryngeal ventricle and involved the vestibular fold, causing fullness of the left vestibular fold. So this would be referred to as a transglottic mass. Beneath the level of the vocal cords, there was several millimeters of normal mucosa between the level of the cricoid and the caudal extent of the mass. The left vocal fold and arytenoid demonstrated severely reduced mobility, about 20% of normal, with complete glottic closure by the vocal cords during phonatory tests. So at this juncture, the presentation of vocal fold hypomobility and the size of the mass were especially concerning for late-stage disease in the clinic. This appeared to be a T2 or T3 laryngeal carcinoma centered over her left vocal cord, of course, pending confirmatory biopsy. The patient couldn't tolerate attempts at office-based biopsies, so an operative biopsy was arranged as soon as possible, and CT neck and PET CT scans were ordered for staging. So CT scan revealed the soft tissue mass measuring about 16 by 8.1 by 19 millimeters. And here we are at the level of the larynx. PET CT scans revealed soft tissue mass involving the left vocal cord extending into the left anterior commissure without definite evidence of invasion through the thyroid cartilage and no evidence of metastatic disease. So the patient soon after was taken to the operating room for diagnostic biopsy. And intraoperatively, the mass was discovered to be causing some glottic occlusion of the airway between the vocal cords. Biopsies were taken and intraoperative frozen histopathology identified numerous lymphoid cells, but no squamous epithelial cells, which was a very significant finding. This tumor was now suspicious for lymphoma and better treated with chemo or radiotherapy, as opposed to squamous cell cancers, which more often indicate invasive surgery and are the majority of glottic cancers. So due to this result, surgery was limited to adequate operative biopsies for flow cytometry and histopathology. And after multiple biopsies were taken, 100% patency was restored to the glottic airway. Post-operatively, by immunohistochemistry, cells were positive for CD3, CD2, CD4, CD7, CD56, CD30, and T-cell intracellular antigen 1, which is a marker of cytotoxic T cells and natural killer cells. EBV-encoded small nuclear RNAs, or EBRs, by in situ hybridization were diffusely positive. So permanent pathology was thus highly consistent with extranodal natural killer T-cell lymphoma nasal type. Pre-treatment EBV DNA titers were 366 and would be used as a marker of disease progression. Bone marrow biopsy revealed normal cellular marrow negative for lymphoma. The prognostic index of natural killer cell lymphoma, or PINK score, was 0, indicative of low risk disease, and so was staged as 1E. And now onto the management. So a multi-institutional phase 2 clinical trial by Kim and colleagues assessed the treatment of extranodal natural killer T-cell lymphoma using concurrent chemoradiotherapy, or CCRT, with cisplatin. And in this study, CCRT was then followed by 3 cycles of etoposide, ifosfamide, cisplatin, and dexamethasone. And this regimen was referred to as VIPD. Previously relied on regimens were what are referred to as CHOP regimens. And these regimens are anthracycline-based and use cyclophosphamide, doxorubicin, vincristine, and prednisone. CCRT and VIPD usage by Kim and colleagues resulted in increased overall survival and progression-free survival in patients with natural killer T-cell lymphoma compared to cohorts treated with CHOP regimens. And so treatment was initiated in accordance in our patient. One consideration at this stage, however, was the hematologic toxicity seen in some patients in this cohort. So indeed, for our patient, cycle 2 was delayed by 1 week, and dosage was reduced by 20% due to anemia from cycle 1, with our patient refusing transfusions on religious grounds. She tolerated cycle 2 with these adjustments without major cytopenias. And cycle 3 was increased to 10% reduction and then was delayed for 2 weeks due to a positive COVID-19 test. Her COVID-19 disease course was mild. Our patient denied fevers but reported fatigue, some dysphagia, mucositis, and taste disturbances. It was unclear whether these symptoms were due to persistent chemoradiation side effects or mild symptoms of COVID-19 infection. Looking at treatment outcomes now. Post-treatment EBV titer was less than 64, indicative of treatment success. The patient began to show a voice improvement within a month after treatment. 12 weeks after treatment, laryngoscopy revealed significant reduction of the left vocal fold mass with the residual edema and erythema of the left vocal fold with bilateral hypomobility. Post-treatment PET-CT revealed decreased activity of the left vocal fold lesion with no hypermetabolic lymphadenopathy or metastatic disease. She had, however, you can see, asymmetric uptake of the contralateral right side, likely due to vibratory compensation by the contralateral vocal fold. The slight fullness of the left vocal fold led to another operative biopsy that showed no residual disease. At last follow-up, vocal fold mobility was normal, about 90%, with patient reporting near baseline voice. The rarity, the anemia, coupled with the inability to transfuse and the uncertainty surrounding the effects of COVID-19 co-infection presented considerable challenge. So I commend the physicians that provided care. Impaired vocal cord mobility often portends a more advanced stage of malignancy. This is the first reported case of natural killer T-cell lymphoma presenting with unilateral vocal fold paresis and was not at an advanced stage of malignancy. This is also the first reported case of natural killer T-cell lymphoma treated successfully with a modified CCRT and VIPD regimen, achieving both remission and return of vocal fold mobility. Recent data show that severe COVID-19 infection disturbs natural killer cell number, phenotype, and immunomodulatory function, excuse me. It remains to be studied how these effects on the natural killer cell populations by COVID-19 influence the clinical course of natural killer T-cell lymphomas and other lymphomas as well. In one case reported by Hassin and colleagues, a refractory natural killer T-cell lymphoma showed transient remission during a COVID-19 co-infection and relapse after infection resolution. So COVID-19 infection during treatment is difficult to diagnose clinically due to shared symptoms with side effects of chemoradiotherapy, but it is still critical to determine COVID-19 infection during cancer treatment, since it may affect the clinical course of certain lymphomas and may be confounded with treatment-related side effects. These are our reference articles. I'd like to thank the American College of Surgeons Florida chapter for hosting this competition and for selecting this case. And thank you all for your attention.
Thank you for presenting that case. We certainly have time for a few questions. I will ask one, which is, you said that, the symptoms of COVID and the symptoms of, treatment, especially for a head and neck cancer, can overlap a great deal. So was her diagnosis because of persistent symptoms, or are your test patients that are getting chemo tested regularly? Is it just part of pre-treatment testing, or it was because she was having symptoms that just had a low threshold to get a test?
It was the symptoms and the need before going into the hospital to be aware of the vaccination status. It was early on in the pandemic.
Okay. So if anybody has any questions, please feel free to put them in the chat box. There is one that says, was a P16 stain performed even though this was not a squamous cell? I understand this was EBV mediated, but also wondered about HPV mediated too.
So a P16 test wasn't performed, or a stain wasn't performed. They found very scant, if any, squamous cells in the frozen section biopsy. And the HPV mediated, so the literature is conclusive that this is an EBV driven disease. HPV has not shown to play a role in progression of this disease or etiology.
And so what is next for her in terms of surveillance?
Well, the patient's happy with her voice, and this is at last follow-up, she showed no evidence of disease recurrence. And so continued observation and checkup. I'm not aware at the top of my head when her next follow-up appointments are, but she remains free of disease and the biopsy was clear, so it seems very positive. So I think if I had to guess, I think or if I had to pass my own judgment, I think it was very fortunate that her primary was in her vocal cord, because if it was in another place, maybe the nasopharynx, the initial symptoms of hoarseness wouldn't have presented so quickly. She had just a 2 or 3 month history of hoarseness, because this disease is known to be aggressive and spread to the skin and other places. So I think if it was in another place where her primary came up and the disease was allowed to spread further, then it would have been possibly, spread further and less of a positive outcome. So to answer your question, for now, it's just continued surveillance and making sure that there's no recurrence, but all signs are positive at this point. But it is an aggressive disease, so it's a good question.
All right, we're coming up on 9 o'clock. Does anybody have any last minute questions? This is your chance to put them in the box. If not, there are mad calculations happening behind the scenes in terms of coming up with the winner. But again, thank you everyone for hopping on tonight. This is our first go round with doing this with the residents and students, and so I appreciate your willingness to present these interesting cases. And
Thank you. It was an honor. I appreciate it.
And for those that don't know, the winner tonight will get a small cash prize, but we'll also get a trophy that can float around between the institution and that is the winner. And the winner by our esteemed judges is Sham Roslin at the FIU for that last case there. So congratulations. And again, thank you everyone so much for coming tonight, and everybody stay well.